I'm pleased to say that many of the people that I speak to now say that they did have some form of information prior to either their surgery for surgical menopause or in fact to their treatment that put them into a medically induced menopause. However, it's not fair to say that that always happens. If you're in either of those situations where you're either going to be put into a medically induced menopause or you know that you're going to have your ovaries removed and that's going to result in you being in surgical menopause, before you start treatment, I would say think about all of the questions that you want to ask and make sure that you get at least an opportunity, even if it's in a phone call, to speak to one of the medical team about your questions. And B is do your homework to the best of your ability.
I'm Shreya Parekh and you're listening to Empower Her, the podcast for busy women aged 35 and beyond. If you're feeling stuck and unfulfilled with your health and wealth, get ready to be empowered to take action. My guests and I will be providing you with knowledge, resources and ideas to help you broaden your perspectives, learn more about yourself and define your path to live your absolute best life. Be sure to hit that follow button to stay tuned with Empower Her and check out the valuable free resources available on the website to support your journey. There are lots of myths about perimenopause, menopause, postmenopause and HRT, and understanding surgical and medical menopause. Join me today with Diane Danzebrink, a personal and corporate consultant, speaker and educator passionate about menopause and mental health. She's also the founder of Purpose Over Profit organisation Menopause Support and has led the call for better menopause care and support in the UK with her national Make Menopause Matter campaign. She's made many appearances on TV such as This Morning, Loose Women, Good Morning Britain, BBC Breakfast, ITV, Channel 4 and much more, and can be heard discussing menopause and mental health on the radio. Diane has also written her first book, Making Menopause Matter, which is out now. Get ready for an insightful conversation as we delve into an in-depth discussion about menopause. Diane, welcome to the Empower Her podcast. It's great to have you on. Please could you talk a little bit about your journey from what you were doing to what you're doing now? That would be great. Thank you so much.
Of course. Thank you very much for inviting me. So back in 2012, I experienced what's called a surgical menopause. So this is where both of the ovaries are removed at the same time. Unfortunately for me, I wasn't given any information about going into surgical menopause. I was not given any information prior to my surgery or post-surgery about surgical menopause. The only information or advice, I guess, I was given was, if you feel you need to, go and see your doctor in a few weeks' time. So I had had major abdominal surgery and I was never given the opportunity to go back and see the gynecologist or any of their team. It was simply, okay, you're discharged. I think I left the hospital about 36 hours after surgery, and go and see your doctor if you need to in a few weeks. I did see the doctor because I had stitches that needed to come out. But again, we didn't have any conversation other than how was I feeling? And at the time, I was feeling okay. I had decided that I would sort of do my best to look after my health and nutrition myself, take it very steady to get back to exercise, etc. And for probably about 3 months after my surgery, the only symptom that I really had was a few mild hot flushes. And really all I knew about menopause in any way at the time was that you might have some hot flushes and eventually you won't have any more periods. Well, for me, I'd had my ovaries and my womb removed, so I certainly wasn't going to have any more periods. It was about month 4 that things changed for me. And it was not my physical health that was impacted, it was my mental health. So I started initially to have sleepless nights, really struggling either to go to sleep or waking up, usually at 2 or 3 o'clock in the morning, not being able to get back to sleep, that deteriorated over a period of weeks to me having panic attacks during the night, eventually so bad that I had to wake my husband, which you can imagine was not great for his sleep pattern either. The anxiety over a period of weeks and months became so crushing that I had stopped working again. I wouldn't leave the house. I wouldn't even go out to walk my dogs. I had stopped really allowing anybody other than my mum to come to the house. I wouldn't answer the telephone, and I even had got to the point where I wouldn't open post, because in my irrational brain, I had decided that everything, everywhere I turned, was negative, because that was how I felt. I genuinely felt like I was going mad. My mum and my husband tried to persuade me to go and see a doctor. I was absolutely terrified. I thought it would either be a lifetime of antidepressant medication or I would be admitted to a mental health unit. So I resisted. Long story short, I woke up one morning after another horrific night, and I looked out of the window and thought, if this is my life several months after that surgery, I can't do this anymore. And it was later that day that I came very close to taking my own life. I'm incredibly fortunate in that my husband took control of the situation when I made him aware of what had nearly happened. I was sitting in front of a doctor later that evening, and I was very fortunate that she understood exactly what was going on with me and took the time to explain the fact that having lost my ovaries at the same time in my mid-40s, that had plunged me into a surgical menopause situation. The symptoms of that can be psychological, cognitive, physical. For me, it had affected me psychologically, and that she could help me, and that she could prescribe me some hormone replacement therapy because I really needed some estrogen back in my body. And at that point, I sort of took a big gulp and told her how scared I was of that, because I'd heard all the scary stories about HRT and breast cancer over the last 20 years. And she again took the time to explain good factual evidence-based information. I did start, and it wasn't a miracle and it didn't work overnight, but over a period of weeks, it was very clear that things were starting slowly but surely to improve. And as things started to improve, it made me wonder, was it just me that was really unlucky, or were there other people struggling? And I did what we all do. I turned to the internet and started to look, and I was just horrified to see so many situations where people were saying, I feel like I'm going mad. I don't know who I am anymore. I don't feel like me. This is affecting my relationship. This is affecting me at work. And I sort of knew I was back to some extent when I remember on one particular occasion turning to my husband, and in quite a loud, grumpy voice, and it certainly wasn't his fault, I said, how the hell can this be right? We're half of the population and there's so much needless suffering going on. If I ever feel like me again, I'm going to make damn sure I do something to change this. So my background is in therapy. I combined that. I did some professional nurse training in menopause, started to counsel women individually, sort of specializing in menopause. Then in 2015, I decided that we needed an organization, a sort of a patient advocate-led organization. So I launched something called Menopause Support, which provides all sorts of things to all sorts of people. I'm sure we'll come on to that. And then in 2018, I launched a national campaign to improve menopause care and support for everybody. So I've sort of, I guess, informally been in the menopause space for about 11 years now, and I guess formally for about 9 years.
Wow. It sounds like with all your experience, I feel like you were kind of like one of the pioneers to start the
start the conversation, because now, I mean, I feel like the conversation is everywhere. Everywhere I listen, you know, it's menopause and perimenopause and things like that. I just want to really distinguish between perimenopause, menopause, and postmenopause. That's the first thing I'd like to do, because I know the word menopause, people just take it as it is, and there's three stages really, and menopause is just that one day in your life, and I think a lot of people don't understand that. So could you just kind of run through those three, and then also I want to talk about surgical menopause, because I don't think many people are aware of that. I certainly am not, and obviously probably because I haven't had any surgeries like that, so I wouldn't be aware of it. But just knowing and being aware of surgical menopause, if someone else had it, you know, at least I'm aware of it and know and can maybe suggest, look, have a think about this.
Yeah, absolutely. So I think I think, as you say, the sort of the transition of menopause and the stages, it is quite confusing, because we generally use the word menopause to cover a transition of some years for most people. But menopause also has its own sort of clinical diagnosis, if you like. So generally, when people are talking about menopause, they're talking about everything during that transition. So perimenopause, peri means around the time of, menopause, if we translate it, means the total cessation of periods. Now, even that is a little bit confusing, because for many, perimenopause begins in their late 30s, early 40s. They might not necessarily recognize their symptoms as being related to changing hormone levels, but those hormone levels are changing more frequently. And that's because what's happening is, sort of physiologically, the ovaries are running out of whatever their store of eggs was. So the egg reserve is becoming very low. And it's at that point that perimenopause begins. And so that sort of fluctuation of hormones that people are used to on a monthly basis becomes more erratic. So during perimenopause, progesterone tends to fall quite hard and quite fast, and estrogen starts to fluctuate, sometimes on a daily basis. And for some people, that can feel quite significant. Around 1 in 4 will have almost no symptoms, but 3 out of 4 do. So perimenopause can last several years. So if you start your perimenopause at 43, 44, you might not get to menopause, which is where somebody has had a consecutive 12 months without a period, until perhaps your early 50s. So that transition can be quite a long time. And then essentially post-menopause is everything after you have reached that stage of menopause. So for most people, they're going to live 30 plus years post-menopausally. So that's what doctors would describe as a natural menopause transition. But then, as you said, we also have to think about other things. So surgical menopause, a medical menopause, an early menopause, and a premature menopause. So surgical menopause, that's where somebody has both of their ovaries removed at the same time. So the vast majority of estrogen and progesterone and some of our testosterone is produced from the ovaries. So consequently, if you have them removed, that's removing a significant percentage of your hormone production. So again, that can put people into a sort of an immediate menopausal state. If somebody is in medical menopause, that is because they are either taking medication or they're having medical treatment for a medically diagnosed condition. So that probably quite commonly comes up with people who perhaps have been diagnosed with a form of cancer, where perhaps they're having chemotherapy or radiotherapy, which has an effect on their ovarian function. So if that ovarian function is changed, that can put somebody into a menopausal state. There are other conditions, things like severe endometriosis, or a condition called premenstrual dysphoric disorder, which is a very, very severe reaction to our naturally changing hormone levels. So I think most people have heard of the terms PMS and PMT, but PMDD is a very severe form of that sensitivity to monthly hormone fluctuations. And if people are experiencing either of those, one of the treatment options is to suppress the ovarian function with a form of treatment. And that's because by suppressing the ovarian function, you can potentially improve both of those conditions. However, it does then bring on menopause symptoms. Early menopause would be anybody who goes into menopause, so has had that 12 months without a period under the age of between 40 and 45. And then a premature menopause would be anybody who experiences menopause under the age of 40. So currently in the UK, roughly 1 in 100 under 40, 1 in 1,000 under 30, and 1 in 10,000 under 20 will experience a premature menopause. But I think when we think about the sort of maybe our friends, our family, our work colleagues, maybe our wider community, 1 in 1,000 under 30, well, that is quite unusual, but 1 in 100 under 40, actually, that's not particularly unusual at all. I think a lot of people are not aware of it, but clearly it is happening around us.
When you go into like premature and like have it fairly early on, like before 40, what are the symptoms? Are they similar?
So so for those who experience a premature menopause, premature or early menopause can be for a variety of reasons. It might be because of medical treatment, it might be because of surgery, but there's also a condition called premature ovarian insufficiency. And that essentially means that the ovaries aren't functioning as clinicians would usually expect them to do for those individuals under 40. Now, for many of them, the first sense that they have that they are symptomatic or that they're experiencing issues will be either they will have several months of amenorrhea. So in doctor speak, that means you've stopped having periods for several months. And for others, it might be when they are starting to think about fertility and trying to become pregnant. Now, for some, they might have associated symptoms, but very often, because maybe menopause has not even entered their heads, they might not be putting the two together around, okay, so I haven't had periods for several months, and I'm also having these symptoms, but they might not be linking them. And equally, somebody who maybe has never been in a situation where they are trying to become pregnant, they might have been having symptoms that they might have they either might not have gone to their doctor to consider them, and even if they have, they might not have been thought about in terms of, could this be related to hormones and ovaries? So I think a really important thing to say is that if any of your listeners think that we might be describing something that they're experiencing, it is really important to see your GP or your practice nurse as a first point of call. And if you are under the age of 40 and you suspect that this could be happening to you, it's really important that you go and see your doctor. And to diagnose premature menopause, premature ovarian insufficiency, you should have 2 blood tests 4 to 6 weeks apart. That will be the initial diagnosis. If you have a doctor who feels that they are equipped to support you, then that's great. But for many, they feel that that needs a referral to a menopause specialist. So that should be the next port of call.
Okay. And with surgical and medical, I just want to kind of highlight, you know, when people do go into hospital to have these procedures, or they're going in for a medical condition, there could be a chance that they do go into, menopause. But how can that be supported? Because, you know, I'm assuming, you know, there are lots of women that go into hospital and have these procedures, and like you, they come out not aware of what could happen. Surely, you know, you know the implications of the procedure. The medical staff would know that, okay, potentially this could happen. Is there anything happening about that? That's the first thing. Because, I mean, you know, it seems quite an obvious thing to talk about. It's like, you know, when you have a baby, the nurses come around and they talk to you about contraception. You know, make sure that you start contraception, make sure you do this, are you breastfeeding? You know, there's 2 or 3 things that they definitely talk to you about. Is this being talked about after women, you know, women going in for medical procedures?
So the truth is that it's a very varied picture. I'm pleased to say that many of the people that I speak to now say that they did have some form of information prior to either their surgery for surgical menopause, or in fact to their treatment that put them into a medically induced menopause. However, it's not fair to say that that always happens. So my advice would be is that if you're in either of those situations where you're either going to be put into a medically induced menopause, or you know that you're going to have your ovaries removed and that's going to result in you being in surgical menopause, before you start treatment, before you have that surgery, I would say, think about all of the questions that you want to ask and make sure that you get at least an opportunity, even if it's in a phone call, to speak to one of the medical team about your questions. And B is do your homework to the best of your ability. So I would be pointing you, for surgical menopause, I would be pointing you to resources like our website, which is menopausesupport.co.uk. There's a fabulous community group called Together in Surgical Menopause. They have a sort of monthly meetup online group. And then to things like Women's Health Concern, which is the patient arm of the British Menopause Society. I mean, ultimately, we should be in a position where anybody going in for surgery that's going to put them into a surgical menopause, or anybody that's going to have treatment that's going to result in medical menopause, should be thoroughly counselled prior to their surgery. They should know all their treatment. They should know about all of the options. And they should be able to, along with their clinician, make the right informed choices for them. I mean, sadly, it's not unusual for me to speak to women who went into premature menopause several years ago and longer, who were not given the right information. And that lack of knowledge about how important hormone replacement therapy for those in a very early menopause can be has resulted in long-term health conditions. Equally, you know, it's not fair to say that nobody gets the right help and support. Of course, some do, but I'm still in the unfortunate position of speaking to women who enter surgical menopause and are told the same as me. See how you feel in a few weeks. Hello, you've just taken my ovaries away. I think there's going to be some implications to that. So see how you go in a few weeks is not only is it not sufficient for me, I would call it negligent. You know, kind of, I would if in an ideal world, and I think we can probably both agree, Shreya, that it definitely isn't ideal, but in an ideal world, I would like everybody going into menopause in whatever form to have the right information before it happens, but particularly for those going into a premature menopause or an early menopause, whatever the reason, I would also like to see support for them, because, you know, I often say to people, imagine being somebody who is 23 and you're told that you have premature ovarian insufficiency. Well, A, it's probably a term you've never heard of. B, you've probably never linked it with menopause. C, that's an enormous shock to your system. That's a lot of information to take in. D, you then have to go and tell the people closest to you, which is a difficult thing to do. It presents all kinds of issues in terms of future relationships, the kind of conversations you're going to have about fertility. Hopefully that's been explained to you, because it's true to say that it isn't always. And then you're probably going to have to take medication for, you know, 30 plus years of your life. That's an enormous amount to take on at any age.
Yeah.
But, you know, for somebody in a premature menopause, then not to have any kind of continued follow-up support. And, you know, often they will have medical support, but we really need some wraparound emotional support for those individuals as well, and for their families.
Yeah, absolutely. I feel like, you know, that there's lots of things that women go through, and the emotional support, you know, medically, yes, you might be supported or told, you know, this is what you need to do. We need to give you, you know, you need to have surgery or whatever that might be. But then the emotional support around that, actually, it, in my view, kind of fails almost. And even with childbirth and things like that, you know, it's almost like, right, you've had the baby, off you go, kind of thing. And the support emotionally isn't there either. And then, you know, we're expected to do all these things without any support and without any, you know, research on women and all sorts of things, really. I want to cover HRT. I know you took HRT, but you know, you pretty much had to take HRT. And there are a lot of myths around HRT. I've heard of them, and that it scares me to take HRT if I needed to. Can you talk about those myths, and also the pros and cons of taking HRT, and how you go about taking it? I've also heard that if you want HRT, or if that's what you should be taking, it depends. It's like a lottery.
Okay, so HRT simply is hormone replacement therapy. So, as I said, if you're in what doctors would call a natural menopause, so that's during this transition, if you're having symptoms that are affecting your quality of life, NICE menopause guidance currently states that hormone replacement therapy is what's called first line treatment. So that ultimately means it's the most effective treatment for symptoms. Now, not everybody will choose it. And of course, it should be all about having informed choice. But I think what has stopped a lot of people in the past is that lack of information and scary headlines. So just sort of, rather than me telling you what I think, I'll tell you what the British Menopause Society say. So the British Menopause Society say that in terms of HRT, for the vast majority of individuals under the age of 60 or within 10 years of their last period, HRT, the benefits significantly outweigh any risks. Now, if you have a complex medical history, that might be different for you. And obviously, if you've learnt all about it and you choose not to take it, absolutely, that should be informed choice. However, we have seen far too many people who have been either precluded from taking it by a medical health professional, or they've not even gone and had the conversation because they've heard scary stuff. So HRT, essentially, if you still have your womb, HRT is replacement estrogen and some type of progesterone. If you've had your womb removed, if you've had a hysterectomy, for the vast majority, it will be estrogen only. If you had very severe endometriosis and you've had your womb removed, you would probably still need progesterone. That's the current guidance. Most hormone replacement therapy is what is in the UK is called body identical. And essentially what that means is that the makeup of the product, the sort of the molecular structure is very similar to the hormones that you produce naturally. So it's really about giving you back, it's very low doses, it's really about giving you back a level of hormone that is going to alleviate those symptoms you're experiencing. And if you still have your womb, help to protect your womb lining too. In terms of the myths, there are, as you say, there are many, many of them. Last year, we produced a 44-page information booklet called Understanding Menopause, which was written in conjunction with 4 wonderful British Menopause Society menopause specialists who gave us their time to help us do that. And we cover huge amounts of those in there. But some of the really key myths are you can't start hormone replacement therapy if you're still having periods. That's nonsense, because for most people, throughout their perimenopause to menopause transition, that's the point of the transition. Your periods are going to be changing, but you're still going to be having them, but you're probably having symptoms too. So what menopause specialist doctors will say is, are your symptoms having an impact on your quality of life? If they are, that's the time to go and talk to your doctor, not just about HRT, but also about other options too. So that's the first thing. So the second thing that we often hear is, if you're prescribed HRT, you can only have it for 5 years. Well, that's incorrect too. Going back to NICE guidance, that says that there is currently no defined timeline for how long somebody can have HRT. It very much depends on their medical history, their personal health, and having annual checkups to see how well they're doing with it. And for some people, they will say, do you know what? I feel really well on it. I'm doing really well. It's really helped. And actually, I will have those annual checkups, but I intend to remain on HRT. You will often hear people say, I've been told that I can't have HRT because I smoke. I have a higher than average BMI. Those things are incorrect. So HRT can be oral tablets. It can be a transdermal patch, gel or spray. As I said, you know, kind of, it's going to be either a combination of estrogen and a type of progesterone, or estrogen only, depending on your own medical history. If somebody has a higher than average BMI, if they smoke, etc., if they have ever had other complications that perhaps they've been told absolutely no, menopause specialists will often suggest that they begin with a transdermal type of estrogen. So that's the ones that go through your skin, the patch gel spray. So there, as I say, these are kind of really common things that we hear on a regular basis. Of course, we do also hear from those who are significantly younger, who have been told, oh no, you're too young, it can't possibly be that. Well, actually, that's when those 2 blood tests under the age of 40 are really important. So yeah, there are heaps of myths. Obviously, the big kind of scary headline that we've seen perpetuated over the last 20 or so years is around HRT and breast cancer. I think every international menopause society has now formally recognized that the research that came from was a flawed piece of research, which has been reassessed many, many times. Is it to say that there is absolutely no risk associated? No, that's not true. But for the vast majority, benefits outweigh any risks. And I think it's all about the individual being able to have that conversation with a medical health practitioner. Now, as you know, I've been running a campaign now for many years for us to have mandatory menopause education for all our GPs and practice nurses, because historically we haven't given them that. And I believe that that's done a huge disservice to our medical health professionals. The knock-on effect of that is that that's done a disservice to their patients. So I think if we help our medical health professionals by updating their knowledge, that will help them help their patients, which is really what they want to do. So in the absence of being able to have that conversation, it's a really good idea to do as much homework using good evidence-based information. And I think one of the things you said earlier, you know, kind of menopause is everywhere now. Well, awareness is everywhere, but unfortunately that doesn't mean that the information is always good, factual, evidence-based information. So, you know, as I said, I would very much point people towards things like Women's Health Concern, our booklet, which, you know, the British Menopause Society have now adopted onto their website as a tool for clinicians. You've got 44 pages of information. I really do think that it probably is everything you need to know to have that conversation with your doctor. You'll find symptom checkers in there. And maybe you'll come across symptoms that you might never have connected with changing levels of hormones. So one of the sort of subset, I guess, of physical symptoms are what doctors call the genitourinary symptoms of menopause. So these are things like increased urinary frequency and urgency, increased urinary tract infections, perhaps things like vulval and vaginal symptoms, dryness, soreness, irritation, discomfort. That's a really important subject for us to be talking about, because for far too many, they live with that discomfort and with those symptoms, not knowing that they're related to fluctuating hormone levels. And there are really, really simple interventions that can be offered for those symptoms in the form of what are called local estrogens. So that you generally hear them called local, topical, or vulval and vaginal estrogens. So these are tiny, tiny doses of hormone. They're not in the same class of medication as HRT. So they are tiny, tiny hormone, tiny, tiny amounts. And local means they're delivered locally and their effect is local. So you might have somebody who's prescribed a cream for perhaps they're experiencing vulval dryness or soreness. You might find that somebody is prescribed with a pessary of some sort, and they insert that vaginally. You might find that somebody is offered something called a vaginal ring. So this is the sort of the brand name for that is an E-string. And I don't often give brand names, but there's only one. And these are all available from your doctor, but these can be so helpful. So these are, the effect is local. And it's really important for us to remember that, you know, the female body has sort of a huge amount of estrogen receptors in that pelvic area. So when those hormone levels start to fluctuate and ultimately deplete to, you know, sometimes almost undetectable levels in postmenopause, it's not unusual for people to be experiencing those symptoms. You know, I often read surveys, pieces of research, and everything that I've seen tells me that currently it's believed that around 70% experience those genitourinary symptoms either during their menopause transition or during postmenopause. So for some of us, perhaps our mothers and our grandmothers will be experiencing those symptoms, but it can be a difficult thing to speak about. It can be difficult even with, you know, your partner, members of your own family. There are sort of cultural considerations that we need to take into account here. So for some people, even within their own peer group, culturally, these things can be very difficult to talk about. And then obviously, you know, if that's a struggle to talk about with people that you do know, then the idea of going to speak to a GP or a practice nurse about something so intimate. So I think the more that we can help to normalize that conversation and say, do you know what, this happens to lots of people, and there are really simple treatments that you can have for that, and you can use it alongside HRT, but you can use it independently. You don't need to be having HRT to use a local estrogen product.
I had no idea about that. Honestly, I really didn't. I just thought, you know, you just take HRT if you chose to and you needed it. But I didn't know about the more localized stuff at all. Funny you should say that. You know, I try and normalize the conversations in my household with regards to, you know, leaking and things like that, you know, with my kids. And my kids are like, Mum, do we really need to know that? I'm like, yeah, you know.
You really do.
Kind of do. Because, you know, that's what's happening, and that's what just happened, or whatever. And I think the more we normalize the conversations with our children or our parents or whatever, then perhaps they will feel comfortable as they get older, or perhaps they might think, actually, you know, we can have these conversations, and or just mention that this is what's happening to me, and, you know, whatever that might be. And I think that's where we really need to start having the conversations.
Exactly, lovely. And, you know, I mean, I have, you know, we've talked about it in the booklet in some depth, and in my book, I've dedicated a whole chapter to it because it is such an important topic. And, you know, it's really upsetting when you think about, you know, sort of our older female relatives. And, you know, I've certainly had personal experience of having a, you know, sort of an older female relative who I can't imagine what the poor woman spent on, you know, sort of on pads and pants.
Yeah.
But had she have been given the right information at the right time, things could have been very different for her.
Yeah, yeah.
And for so many like her.
Yeah, yeah, absolutely, absolutely. And the key thing is, I think what you've said is, you know, there's so much information out there now.
Yeah.
But really do your own research and fact finding. And there are websites, like you mentioned, you know, starting from your website, and you know, that has the information to equip you before you even make that appointment with the GP, so you are aware of your choices as well.
Yeah, absolutely. And I mean, the other thing to say is, you know, sort of we're always very happy to point people in the right direction. So, you know, if anybody's listening to this thinking, I don't know where to start, you know, you're very welcome to email us and say, I can't find this on your website. Is there somewhere I can find it? And, you know, it might take us a few days to come back to you, but we will always come back to you.
Yeah, no, absolutely. Quickly touching upon post-menopause.
Yeah.
Not many people talk about that.
No.
What are the symptoms? Do they just carry on, and is there a point where it will just kind of stop? Or, you know, I don't know anything about post-menopause, to be fair.
Yeah. So, I mean, post-menopause, I think, is if we think back sort of 10 years, I think very few people were aware of the term perimenopause. Thankfully, that's changed hugely. I think we still have some work to do with postmenopause. So with postmenopause, in terms of symptoms, as I said, 1 in 4 will have almost no symptoms at all, but 3 out of 4 do have symptoms. So as those hormone levels deplete to those much lower levels as you reach menopause and beyond, for some people, their symptoms will abate. However, it's not fair to say that's the same for everybody. So unfortunately, some people do remain symptomatic. And what's really important about that is not to feel as though because you're postmenopausal, you just have to put up with it. Even if you've never sought any help and support during your perimenopause and you're now postmenopausal, it is really important that you know that there potentially are interventions that could help you. So, again, probably your doctor or your practice nurse is your first port of call, but you might need to be referred to a menopause specialist too. That's sort of, that can be tricky depending on where you live in the country, but everybody should have access to that service if they need it. A lot of it, thankfully, now is done by video call and telephone. So even if there would be a significant distance for you to travel, you can still have that appointment without the inconvenience and often the cost of that too. So one of the things that I say to everybody is, whatever stage you're at, look at the things that you can do. Look at the things you can do for yourself. So think about your overall lifestyle. Think about whether or not there are things that you could change that would help to improve your symptoms. So think about things like, how am I nourishing myself? Am I getting good nutrition? Am I taking whatever form it is that works for you, but some sort of exercise? Am I optimizing my sleep, or am I spending the last moments and the first moments of my day on a device? So think about optimizing your sleep. It's very easy for me to say, see what you can do about your stress levels, but there are some simple tools that you can use to help with that. But if none of those things have helped, and you might have tried over-the-counter products, then it is really important to have that conversation, because unfortunately, again, due to sort of the media reporting, particularly over the last 20 years, and all the scary stories that there have been about that first line treatment, hormone replacement therapy, we've seen a lot of people who've said, oh no, I couldn't even think about having that conversation. And we speak to them perhaps in their late 60s, in their 70s, and they're telling us that they're having those genitourinary symptoms. They're still having hot flushes. Those hot flushes are affecting their sleep. They have these joint pains, these aches that they can't get rid of. For some people, it will be, sort of those cognitive and psychological symptoms. But I would say most commonly, we tend to speak to people who are experiencing still those hot flushes and night sweats, the changes to the broken sleep, and those genitourinary symptoms. And there are definitely options that can be considered. So I guess, sort of my advice would be, please don't suffer in silence.
Could this go on into your 70s then?
So for a small number of people, they do experience symptoms ongoing. But I think, this is why the conversation and the information at the right time is so important, so that we'll get to a stage where we don't have people who are suffering but not knowing that there is something that can be done to help them.
Yeah, absolutely. So, Diane, I'm a really big advocate for collaboration, not calibration, collaboration, as you know. What collaboration opportunities are you looking for right now with the campaigning that you do, and whether that's personal or professional?
So essentially, lovely, I guess it sort of falls into two camps, really. The first one is, we are always really happy to have conversations with, particularly with sort of grassroots community organizations, where they are doing their best to support members of their community. It's usually done on a shoestring or with absolutely no funding whatsoever. But because we have been in a position where we've been able to create these resources, we really want them shared as widely as possible. So we don't have the funds to be able to do a huge marketing and publicity campaign. So generally this comes through kind of having those conversations. So I'll give you an example. I've just had a conversation where I live with the person who basically oversees all the food banks in my area. So that's within my particular area. There are 33. Some of them are mobile units. And what we have arranged between us is that Menopause Support will provide booklets for all of those sites. And menopause is something that they are starting to find that the people that are using their service are starting to talk about, because obviously a food bank is much bigger than helping people with food. It's also, those people they're providing all kinds of other support. So that's a brilliant collaboration for us. I'm also just teaming up with our local sort of community foundation, who are the umbrella organization for lots of sort of third sector organizations, charities, social enterprises. And I'm going to provide an education session for them. So that means that we'll reach a huge amount of people by me going along and giving up a couple of hours of time. So those things can be done online if you don't happen to be in my particular area. We have PDFs of the booklet. We have a fabulous 5-minute animated film, which is a free resource. But it's really being able to sort of widen our network, I guess, in terms of that community support. And then the other half of it, as any charity or community interest company will tell you, is about funding. So we are blessed at Menopause Support to have a wonderful, wonderful little group of people who have supported us for several years. And essentially, Menopause Support wouldn't be here without them. However, we've got lots of projects that we would love to do to help us to create more of those free resources, to help us provide more free support for individuals. And we need funding for that. So if any of your listeners would like to get involved by, not necessarily by individually sort of supporting us financially, but perhaps you might work for an organization that has a corporate social responsibility fund. Perhaps you might know of great funding opportunities that you might like to share with us. All of those things. Again, it really comes down to community. It's all about us sort of supporting each other. Then that would be absolutely fabulous. So yeah, we're always open to hearing about those things, because I'm sure that you've spoken to other people who do similar work in the women's sector generally. But the tragic facts are that less than 2% of charity funding goes to projects that specifically support women.
Wow.
And so we're in a very any project that's supporting women is in a very difficult situation at any time, particularly at the moment with the financial situation that we found ourselves in sort of in recent years. So with less than 2% of charity funding overall going to women's projects, and then you think we're focusing specifically on menopause, which is not just about health. You know, there is all sorts of things to take into account. It's about mental health, it's about relationships, it's about keeping people in work, it's about socioeconomics, it's about culture, etc., etc. There's a huge range of topics in there. But when you kind of further subdivide that, it can be an incredibly difficult landscape in terms of funding. So if anybody has any great ideas or great connections, then I would, of course, love to hear from you, because that will definitely help us help others.
Yeah, I really think it's about connecting the dots. And if someone knows someone that could help, it starts with a conversation. If it doesn't go anywhere, it doesn't go anywhere. But it just starts with that one conversation.
Absolutely lovely.
Yeah, brilliant. I think you are doing an amazing job. I mean, it's amazing how far you've come with the charity, and I really do hope that people get on board and support you. I certainly will be doing that, and I'm trying to connect you with as many people as I can. That is for sure. Diane, thank you so much for being on the Empower Her podcast. It's been great to have you on, and thank you so much for your super insightful information.
Thank you so much for inviting me. I mean, if anybody wants to get some of those information resources that I've talked about, just head to menopausesupport.co.uk. And as I said, if you want to get in touch with us via email, I assure you we will come back to you.
That's great. No, all the details to get in touch will be in the show notes and through the promotions as well. So yes, lovely. If anyone's listening that wants to find out more, have a look at the show notes and obviously all the social media. Thank you. Thanks so much, Diane.
Thanks so much for inviting me.
Thanks for tuning in to Empower Her. I hope today's episode has left you feeling inspired and motivated to make a positive difference in your world. Please follow the podcast and share it with anyone who will find it helpful. Until next time, keep striving for positive change and greatness for all women.